So fitness, and what is the point of talking about fitness? And what is the way, as a surgeon, we perceive the fitness on our patient? Do you know this guy? Who knows? You know, the English contingent knows, but the non-English contingent knows. This is John Alomo. He's a legend. He's a legend of rugby. Is that right? Is that what we have to describe? He's a legend. He died recently, bless him, and he's a recipient of a kidney transplant. He's an amazing, powerful player of rugby. You know, if anybody has ever seen John Alomo playing, he's just sheer power, excellent fitness, bright mind, excellent player. So that's what he was. So what the surgeon mean in terms of transplantation, we would like to have patients like him, essentially. So that's exactly what we would like to see. Patient who is fit to receive a transplant, clearly it has enough cardiac resistance, physical activity, and resilience to the insult that we produce to the patient. Fit to wait while we get the transplant. Because when John Alomo, we will talk better later on in the presentation, needed a kidney, there have been some sort of popular response where people was queuing outside a radio station ready to donate a kidney to the legend of rugby and in New Zealand. But that's not the case for the vast majority of our patients, to have thousands of potential donors, living donors. They have to wait on the waiting list, and maintaining the fitness on the waiting list is another crucial factor for a successful outcome. Fitter after the transplant is what I can learn from you, how a patient can maintain their fitness after the transplant. But the initial period is quite crucial, where weight gain, cardiovascular insult, infections can certainly dent the development of an appropriate fitness. And fitness of donors is a quite important factor that I think it is, you touched very briefly on talking about different type of donors. The living donors that we are seeing in the UK is a major impact. We are probably not looking after their fitness after an operation enough. And that is something I can see my colleague from King's College nodding, and that is an aspect where I think your research would be extremely interesting to apply. You'll know him. I have to say that it was a beautiful exercise during this, where I was preparing this presentation, looking at all the athletes that had received the transplant. And anyhow, they must have something in common, and we'll talk about this. So merit is an example. It's clearly an example of the ideal patient you would like to see. Motivation, fitness, like John Alomo, you know, is certainly, but he's not representative of the average population that we see. I don't have this patient. That's not the patient I have. And this is really the reality. In reality, all patients who have end-stage renal failure, we cannot transplant all of them. We can transplant in a successful and a good, accessible service, probably 30 to 40%, maybe 45% of the patient with end-stage renal failure. And again, I'm a simple transplant surgeon, I'm not a nephrologist, but they can tell you what are the barriers to transplantation. And I don't want to try to be too boring on this. So they are certainly older. Kidney disease is not anymore a disease that has been observed in the first 2 or 3 decades of life. We see patients, and more patients, who are 50, 55, long history of diabetes and hypertension, the cardiac functions are not that good, and they present to us with the hope of receiving a kidney transplant. This is what it is. But this is what it is because things have improved in the course of the years. In the course of the decades, we do now transplants on patients that we were dreaming to do about 20, 25 years ago. And this is really how medicine has progressed, giving the opportunity to more and more people to be receiving a transplant. And not just kidney, and this applies to heart, lungs, and so on. Any kidney transplant recipient here? Anyone who received? Because you said heart. Did you say heart? Both. On the heart. Any kidney? Someone received a kidney transplant? And often, these patients that are waiting on the list, they don't have all that time available to wait for an organ to be available for them. Often, the window for transplantation can be rather small. And yes, the problem is that the availability of organs, and therefore the transplantation, does not happen. Then patients don't progress, or as it happens in the transplant waiting list, in the kidney transplant waiting list, you have the patient get suspended, and the fitness gets reassessed and postponed, and we see our patient fading in front of us. I'm a doctor and I have to produce some graph, I'm sorry, but it's very simple, just to look at. On the top line, you can see how it is in the UK. These are official data from NHS Blood Transplant, which is the agency supervising transplantation activity in the UK, for which I work as well. And you can see we had a peak of patients waiting for an organ that was up to 8,000 in 2009 and 10. And now seems to be reducing. Some people say that this has been reducing. Which one is this? Has been reducing because we have been increasing the number of transplants. I really doubt that, personally. I cannot demonstrate scientifically that. But here, we were increasing, and the waiting list was increasing. Now that the transplant carries on increasing, is it because we are not giving the same access to people? Certainly we have been more successful in terms of numbers of transplant, but my concern is probably because of the lack of organ availability. We're not giving the full access of full organ transplantation to all people that actually need. John Aloma again, I'm sorry, that's a famous try that he scored versus England again, I'm sorry, but that is terribly famous. He literally has been carrying a man over him and didn't decide going left or right, just went through one of the defenders, and that was quite an impressive one. But the parameter of fitness that we immediately try to assess when we see someone in our clinic would be age, of course. But age alone is not really a major impediment to receive an organ transplant. Either extreme, either too young or too old. Doesn't seem to be the older transplant I've done was on a 78 years old. But what is important is to have the realistic expectations from that and the appropriate assessment of the recipient. When we talk about cardiac function, so we have different perception, again, about what is a cardiac function. Is it good enough to live with, or good enough to cope with a stressful procedure like an organ transplant? And that is where the difference comes from, because the stress of the assessment cannot be really fully assessed once for 3 years of waiting. Needs to be monitored and kept. That physical attention on the cardiac functions needs to be kept on, going on and on in the course of the years. Body mass index. Yes, body mass index. We can talk about body mass index. He had the body mass index of 36. I want to say that he was unfit. Clearly, there are limitations on body mass index. And we have to remember, as much as immunology, that has been a major barrier for organ transplantation in the course of the years, but now there are so many advances with immunosuppression that we do things, again, that 20 years ago we were just dreaming about. And just, first of all, is the bioincompatible transplantation we perform. So this is just to give you an idea of the typology of donors that we see in the United Kingdom. And on the grey column is the living donors. Yes, these are the living donors. 1,092. This has been what has happened in the UK in the last 10 years. So we had the boom of living donation, predominantly kidney, but even liver and lungs in recent years is coming up. And these are the two typology of deceased donor that we witness in the UK. And then a special of the UK is the donors have the circulatory death, the DCD, which is not something that is done widely across Europe, but in the UK is an important source of organs. And donors have the brainstem death, which are the normal type of donors, if you want to say. And you see how this has been sort of relatively steady over the last 2 years, and how the DCDs have been quintuplicating literally over the course of the years. This is an amazing guy. I didn't know about him before doing this presentation, I have to confess. Chris Cluggett received a liver transplant, and he's the only Olympic medalist who has ever received a transplant. And he is no border. It's just amazing. It's a beautiful picture as well that I couldn't avoid to put it. And he didn't wait that long. He was being put on the list, and he was transplanted really very quickly because he comes from an area where there is quite a lot of organ donation, and also, I suppose, the allocation of organs sometimes does privilege the most fit patient and so on. But this is a different type of topic. Again, another graph, just to show you here how in the UK the average weight for a kidney transplant. Beg your pardon. I showed you too many things. So, yes, the average weight is 1,000 days. This is 3 years, pretty much. It's a lot of time. How we expect someone to remain fit for 3 years on dialysis? And this is the question that I keep asking, really, not just to myself, but to my patient, to the support workers, to the people working around us. It's 3 years of time that you have to remain absolutely fit. You must not put weight on. Your heart has to be perfectly functioning. You must not have any hiccups in order to be called in the middle of the night and receive a kidney transplant. That is how it is. Is that realistic? Who thinks that it is actually realistic to maintain fitness for a 55 years old? You are absolutely right, because our patients are, they're special in many ways. They expect this kidney to come. They expect their life to be changed in front of them very quickly. And they put all their effort to maintain their fitness. Some of them, they don't, and that is unfortunate, but it's very true that the motivation and focus of the vast majority of patients on dialysis are waiting for a kidney transplant is really very high. And these are, again, the type of kidneys that we transplant, living kidney transplant coming from a DCD or a DBD. And last year, we did perform 2,700, just short of 2,800. I like this picture a lot. He's a golfer. He's a professional golfer. I'm not a golf fanatic whatsoever, but it was a beautiful picture, and he was proudly showing the sternotomy of his heart transplant in this picture. He's very competent. It's just an impressive story as well. So what is the gold standard then? What is the thing that we should, where would be our ambition? Where is the challenge? And the challenge is around preemptive transplantation. And preemptive transplantation is really the goal. And if we think for a second, any other organ is transplanted preemptively. Liver is transplanted preemptively. There are a few cases that are transplanted like urgent or super urgent cases. Heart, the same thing. Lungs, the same thing. Our patient, the vast majority of our kidney transplant, are patients with end-stage renal failure, with no functions. Functions are gone. They need dialysis. So this is important in order to remember, because they will have the opportunity to preserve cardiac functions, to preserve overall fitness, to avoid the risk of related to renal replacement therapy. It can be either peritoneal dialysis or hemodialysis. There are risks. It's a planned procedure. It doesn't happen in the middle of the night with all the psychology and emotion that are involved in the happening of the transplant. Is this kidney good enough? Is the surgeon too tired? Is this going too much? So all the questions about your outcome, they come across quite strongly. And clearly gives also the opportunity to keep having a set date. You keep motivation and focus in a better manner. What type of kidney transplant do you think he received? Preemptive, living donor, or a deceased donor waiting 3 years? clearly he received a preemptive living donor from his mum. And Sean Elliott is a champion. He's in the sport. I didn't know about him either before doing this presentation, but it was fascinating to see. And how do we compare? Because if we look at the actual need of organs and the number of transplants that are performed, you can see how is the geography of transplantation. And you see that, for example, Finland scores very nicely in there for 59.6. Spain scores very well, France very good, UK. And these are only the kidney transplant from deceased donors. Another picture, he received a kidney transplant as well. It's just impressive. He's one of the best 10 blockers in the NBA, in the history of NBA. I didn't know about that, of course, before doing this presentation, but it was, but I can show up. So when we look at the kidney transplant rate, it is quite impressive to see how things change when we put the living donation in the context. And we put living donation in the context, and the geography changes slightly. And the Netherlands, they go on top, 59.8. Spain is still very good. And the UK is there, despite the fact that we don't have enough donors, or not as many donors as the rest of Europe, pretty much. We do more transplant, more kidney transplant, and that is the thing. And what I found really interesting is a country where I come from, is Italy, has a much higher rate of donors, but still remarkably lower rate of transplant performed. This is an amazing story. This is again, I learned about this very recently, and he's a coach, he's a baseball coach at Wake Forest University. He donated a kidney to his one of his athletes that is doing amazingly well. Kevin apparently is being tested for one of the majors and probably would play for a big team. No idea about baseball, but it's an amazing story, this one as well. Again, preemptive living donor transplantation. Again, when we look at kidney transplant rate and we see how small is anyhow the percentage of transplant that are performed worldwide, you can see that anyhow 17.3 or 31.8 per million population is still very little. This is interesting because we don't have many heart transplants in the UK. We have a very low rate. And Simon Keith, this is one of the longest survival of heart transplant performed at Papworth Hospital in Cambridge, and John Walworth is his retired surgeon. And when we look at this, when we look at heart transplantation, that is the problem. It is very low, because donors from brainstem deaths are very, very few in the UK. Ivan Klasnic is famous. I knew about him. He's a footballer. Again, he received a living donor preemptive kidney transplant. And he wasn't a great player, but he was good enough to play in the Premier League and in the Bundesliga. And this is the slide that I think I like most, is where we look at the kidney waiting list versus the actual transplant rate. So what is the offer and the demand, the need and the actual how we satisfy the need? And this is really quite interesting, because in the UK, we have 89 per million population, but we managed to satisfy 50.4 only per million population with a kidney transplant of any form. And the US is even worse. France, despite transplanting very well, again, very high demand. So even if we do our best, we are still falling very much shortly of the need. This is, I think, the last picture I have. And these are they were forming a defensive line, I think, of the Dallas Cowboys. And Ron Springs, he's diabetic, and he received a kidney from Everson, who was his teammate. And Ron recently died through different non-related transplant condition, but he's, again, another amazing story. It's a living donation. Probably a bit too late. He discovered to be diabetic only too late. What is happening in the UK, and that is the nice story to close with, is about altruistic donation. And I don't know if you are familiar with this concept. Someone who wakes up in the middle of the night and said, well, actually, I have a kidney I want to give to the community. Someone can receive a kidney. There are people that need it. Our living donor rate, for which we are very proud of in the UK, is very high. But it wouldn't be so high if it wasn't for these 94. So it wouldn't be so high if it wasn't for the altruistic donor. So again, people, good Samaritans, wake up in the middle of the night and say, "Oh, I give a kidney to the community," and they're doing very well. The kidney is allocated in the same way an organ is allocated from a deceased donor, and they have been topping up, giving us the opportunity not just to perform a single transplant, but to perform a domino transplant, to create a cascade of organs, not just because you look at this living donor, eventually from one we can generate more than one thanks to paired exchange. So I'm not compatible with you, but I can be compatible with someone else, and thanks to the first donor we create a cascade of organs, something that they have been exceptionally good to do in the Netherlands, and we have been copying and importing the system that they have been implementing in the Netherlands. So in conclusion, any French in the room? No, that's good. If we want to be successful, like Portugal, and if we want to be successful, I think we really need to address the real challenges. The real challenges is that we have low rate of donors. The demand remains high. Even if we want to be complacent with ourselves and say we do a fantastic job, yeah, probably we'll do it, but eventually the demand remains still high. Patients are our ambassadors, and I strongly believe that, but not just ambassadors of a service, of a hospital, is actually of an overall international movement or international need, as is happening today here in Finland. And the focus of the attention, in my opinion, and seeing also how our administrators work, cannot be just on the good outcome, on the nice stories. Has to be on how we can win the attention of the politicians. And the attention of the politician is won only on money. And I'm sorry if I am so rude, but it is on finance. And the overall importance of transplantation can be compared in healthcare. Because if I think not just the saving that a kidney transplant creates through removing one patient from the dialysis, I have to think also what are the number of admissions and costs that the NHS or whatever healthcare service has related to that patient. If we don't do that analysis, and if we don't put healthcare in focus, we will never win any major strong argument. Not in the UK, not in Europe, not in Finland, not even in Italy. And the debate about opt-in or opt-out, I'm not going to start a conversation about now what is the best system. But whatever system has to serve the clinical need, doesn't have to serve what is the personal belief, ethical, religion, and so on, has to serve the clinical need of a population. I remain optimistic. I'm a transplant surgeon, and I'm by definition an optimist. There are so many things happening all around the world that really makes me think that we can, in the future, will be able to satisfy. We might be able to have a waiting list of 0, maybe. And this is just a thank you and a goodbye. The other day I was explaining this concept about altruistic donation during an altruistic donor to one of my medical students. And we were talking about this. And then suddenly I was looking around and I said, "Are all Italians? We're all Italians." And my anesthetist is Italian, my scrub nurse here, Antonio, is Italian, my assistant, Flavia, is Italian, and even my medical student is Italian. So that's Brexit. Thank you very much.